This is Dipti Itchhaporia. I'm the Vice President of the American College of Cardiology, and I want to welcome everybody on the behalf of my colleague, Dr. Harlan Krumholz. He and I are going to be moderating this very interesting session about COVID. I am an interventional cardiologist in California, and as I mentioned, I'm the Vice President of the American College of Cardiology, and I'd like to introduce Dr. Harlan Krumholz, my co-moderator for this morning.
Hi, I'd like to welcome everyone for joining us. I'm a cardiologist, as she said, at Yale University, and I'm honored to be part of this group. What we've done is tried to assemble an extraordinary group of people with an immense amount of wisdom about the pandemic, much of it earned on the front lines, but also built on careers of contribution in cardiology and in expertise. And they've kindly opted to join us and to help share that wisdom in this webinar. And the goal is really to disseminate knowledge. And let me just say that this is just really an example of how, when challenged, cardiologists around the world come together for common cause to contribute in ways that will help patients everywhere. And that was our intent goal for today and for the ACC in pulling this together. We've done something else in trying to put this together, which is we put out a call for questions. The goal here really was not to provide fixed presentations or more typical scientific talks, but rather to respond to the questions that were posed to us from people around the globe, really. And many of these questions are posed in a way by people who have not yet encountered the pandemic, but are anticipating it or have encountered it to some extent, but want to hear from people who are in the midst of it and have more experience. So the way we've organized this is to bring these experts together. We're going to give them a chance to reflect a little bit at the beginning on their experience, a little bit at the end, and then Dipti and I are going to try to go through these questions in as efficient manner as possible and give these experts a chance to share their perspectives about them. What we would like to do first is just to give our guests a chance to introduce themselves briefly, and then we'll give them a chance to reflect on this. So let me just open up to our guests. First of all, let me look at all of you, welcome you. Thank you for joining us, and maybe just go around and each of you can just jump in and introduce yourself. Sahil, do you want to start?
Sure. Thank you, Dr. Krumholz, and it's a pleasure to be here. My name is Sahil Parikh from Columbia University in New York. I'm an associate professor here and an interventional cardiologist focusing on vascular medicine and intervention. I'm an active outpatient cardiologist as well as an inpatient cardiologist, and we here in New York are at the moment quite inundated with COVID-19 patients. So we've cared for a variety of patients in each of these venues. So delighted to be part of this panel. Thank you.
That's great. Kim?
Good morning, and thank you so much for having me. I'm Kim Williamson, Chief of Cardiology at Rush University, and I just want to shout out to Dipti for putting this together, and Harlan for all of your international ability to put people together. So thank you so much for doing this.
Great. Jambal?
Yeah. Hi, good morning, everyone. Good morning, Harlan, and good morning, Dipti, all colleagues. It's really honored to be involved in this program. I'm Dr. Ge, and interventional cardiologist in Shanghai. I'm a director of the Department of Cardiology in Wuhan Hospital, Wuhan University, and also now the president of Chinese Cardiovascular Physicians, and also the chairperson of Chinese Cardiovascular Association. I would like to share my perspective and also experience in the management of COVID-19 in the last 2 months. I could try my best of any help. Thank you very much.
Thank you so much, and so appreciate your leadership on the 2 prior webinars that we had, so well received and so important information. We're still hearing from so many people around the world about their appreciation. Thank you for your leadership of that. Mikhail?
I'm Michele Senni. I'm the Chief of Cardiovascular Department and Cardiology Unit at Papa Giovanni 23 Hospital in Bergamo, Italy.
Thank you so much. Sean?
Hi, everyone. Thank you for having me to join this meeting. Thanks, Harlan and Dipti. I'm an infectious disease physician and by training, and I work as the clinical director at the National Center for Infectious Diseases in Singapore. and it's a 330-bed facility, and we've seen the bulk of the nation's COVID patients. Thank you.
Thank you so much. Simon?
Hi, it's a pleasure to be here. Thank you very much. My name's Simon Ray. I'm a cardiologist in Manchester in the northwest of England, and I'm the president of the British Cardiovascular Society.
That's wonderful. And Akriti?
Hi, thank you so much for having me. I'm Akriti, one of the cardiology fellows at Columbia University, and I've been on the front lines for the past 3 weeks taking care of patients in the ICU setting. So anything that I talk about today would be from the ICU perspective. Thank you.
That's great. So the first thing we wanted to do was just give everyone a chance to reflect a little bit. And what we've done is just pose 2 questions to them to start, and we'll go through the group again. And the questions are, what's the most important thing you've learned in the process of this so far? And as an addition, what surprised you the most about this that was most different from anything you'd encountered or had done previously? So Sahil, why don't we'll go in more or less the same order. Sahil, do you want to go ahead?
Sure. I mean, I think that the lesson is that there's no such thing as over preparation. I certainly think that we did not anticipate the acuity and the volume of patients that we would be encountering here in New York. We certainly had prepared fastidiously, and I think we certainly are still preparing in many ways. We're opening new intensive care units and recruiting faculty to come in and support the front lines to the extent possible. And all of us have been brushing up on our ARDS management and treatment algorithms for patients in the intensive care unit. And I think that's really the key thing, is that it's all hands on deck. And really, if you're lucky enough to be in a position where you're not all hands on deck, that would be fantastic. But certainly here, everybody's contributing to whatever extent they can.
So Harlan, I think it's my turn. Is that right?
Yep.
Yeah. So
I was muted, Kim.
no worries. I was actually going to give a tiny Rush University introduction to try to answer your question. The preparedness is really something that we have focused on. It turns out that Rush University was actually designed specifically for this. It had to do with the fact that I should be sharing the screen now, and there we go. So if everyone can see that. So this is the view from the Eisenhower Expressway, believe it or not, just about 2 months ago now, when this was first coming out. Knowing that Rush was designed specifically for preparedness for disasters, we were trying to mitigate it by asking everyone, and hopefully, millions of people went by this and saw this message right on the side of the university. As it turns out, Rush University was actually built in 2012, and it was designed in a very unusual geographic, the butterfly they call it, but if you looked at the flooring and the whole concept of it, it was really disaster preparedness. It was actually funded in the wake of September 11th to be convertible into a huge intensive care unit. And so without going through every floor, unless you wanted to come and visit, when we've upsurged to intensive care capabilities, we actually have 175 intensive care unit beds, which is about 1/4 of the entire state of Illinois. So in addition to that, we have redesigned the emergency room to have inflow areas where people can be screened, handle over 65,000 people. There are interest bays that can be covered, so we could do a lot of triage and screening. This beautiful pavilion that we sort of, host people and, host gatherings and take pictures, all of a sudden became an emergency room extension because it's built right next to the emergency room. So the surge preparation and will take you have your GI endoscopy suite, and within 2 hours, that's an intensive care unit. And so we've actually been able to take each of the units of and double the number of bed capacity just by changing them in from single rooms to double rooms. Adding the walk-in clinic, adding the drive-through clinic, and the major thing that we're doing in cardiology to try to employ everyone is virtual visits. So we've been redeploying people in cardiology as intensivists and as well as hospitalists. There isn't much cardiology per se going on, but we are indeed working very hard to try to support the institution as a cardiology division. And we've done everything we can to try and see our existing patients online, doing some telephone, but mostly video. So that's where we are, and it's been an amazing transformation. And I'm glad that the people before I got there actually thought of all of this, and we can benefit from it and try to contribute to what's happening in Chicago.
Thank you very much. Jumbo, you want to just give a few reflections from your perspective?
Okay, yeah, I think I have a lot of things to tell. And in the previous communication, I think I shared my my own perspectives regarding how to manage this COVID-19. Because frankly to see, when this outbreak in last December, the whole field was not prepared. The hospital, the government, we are not prepared. Suddenly, so many patients, and you know, each hospital, we have only, by the fever clinic, only maximum of 20 to 30 beds. You have 1,000, 10,000 of patients waiting. You see, at that early phase, we do not able to handle so many patients. Therefore, you see a lot of patients, they have a bad outcome. Yeah, since the January 23rd, we sealed off the city, and we are built in 10 days and less than 2 weeks, 10,000 beds with the we call mobile cabin hospital. We try to admit all the fever patients as much as possible, and we send 42,000 medical personnel to the single city Wuhan. Therefore, within about I think 1 week, the whole situation was under control. And you will find that in the early phase, we have a lot of patients which died. But now, especially in the late phase now, recently, we do have still some patients, either the passengers or travel back, but we nearly have no patient died. And also, we have all these 42,000 medical personnel. We have 0 infection. I want to say that it is extremely important to protect the medical personnel, all the patients, all our whole population, and either using the face mask, you wash your hand to avoid gathering to the crowded area and so on. I think what I want to tell is, we do not have specifically medication to treat this kind of specific virus, and the patient we can handle is only for the we call support management or support treatment. We wait for the patient themselves to recover, and therefore this is extremely important that to protect the patient, the population not get infected, and this could block the transmission.
That's terrific, and all those are good messages. I think the message about being able to protect the frontline workers, which we heard from you before, about how you're able to achieve it with care in terms of people with the PPE is so important. Sean, do you want to take next?
Yeah, well, I work at a 330-bed unit, which was purpose-built for outbreaks. It was modeled after SARS in 2003, where we had about 238, almost 300 infections there, and it was a moderate-sized outbreak. And what surprised us this time was that the coronavirus would spread with such rapidity and speed, and it is very different from its cousin SARS in 2003, because that really was a nosocomial disease. There was community spread, but then multiple outbreaks were nosocomial, and that triggered a lot of the infections in Singapore during that time. And what we are seeing now is a virus from the same family group, but it is a community-based spread which is predominant, and it has affected multiple countries and multiple people with greater rapidity. The other surprising thing that we have from this outbreak is the whole spectrum of disease, from very mild and asymptomatic and spreading possibly in the pre-symptomatic phase a few days before onset of clinical symptoms, and to a syndrome which is very reminiscent of SARS in 2003, where people are in cytokine storm and are severely ill in the ICU, and affecting young people too. So that was some of the lessons that we have gleaned so far. The other lesson is that we cannot be complacent. I think Singapore, although geographically we were nearer China, the initial site of the outbreak, and we saw initial waves of infection, we had a slight reprieve with very stringent contact tracing and isolation. But now, as of today, we have had our biggest increase, and the country is now on an exponential phase with multiple infections. So we are bracing ourselves. And one thing which that was not to be complacent, and the one last thing is not to take your supplies for granted, whether it be ICU medications. You might have enough beds, but you may not have enough manpower. You might have enough beds to ramp up and search, but you might run out of medication. So it's very important in search planning not to just look at physical beds, but look at manpower, look critically at your ICU drug supplies, and plan carefully. We used to throw our N95 masks after each entry into each room. We changed that rapidly because we knew that the global supply is uncertain and it was an awful waste. So we have become very stingy now, and we are conserving even in a place which is relatively more resource rich compared to many parts of the world. And so we see our experience, the experience in many countries replicated around, and we are in that phase now in Singapore where cases are climbing.
Thank you so much. Mikhail?
Yes, thanks. I think we have to make some consideration that, first of all, Italy was the first Western country that was affected by this COVID-19. And we were not prepared for two reasons. One, because we didn't have any experience as the Asian countries that had experience with SARS and MERS. So we didn't know how to face epidemic disease such as this disease. At the second point, we were not prepared because, we thought that Asia was too far, very far from us. And therefore, we didn't think about it. We thought that it could be like SARS or MERS, and probably we didn't have correct information about how much is aggressive this infection. And we have to think that Bergamo is the most affected town in Italy, and probably was the first Western town in Europe and the world. And we had more than 9,000 COVID positive patients, more than 2,300 Asian painted death. But we are sure that the death will be much more, unfortunate. And the first case at Papa Giovanni 23 Hospital is dated February 23, but the infection was so unexpected, so violent and prolonged that someone say that is similar to a tsunami or perfect storm. I don't think it's correct, because tsunami and perfect storm, the duration is 2-3 days, not more. This is 40-50 days that we are living in this condition. It's more similar to a trench warfare. And it's something that is amazing in terms of organization, as already seen in United States they made a similar thing in terms of increasing the beds. And I think there is some issue that should be underlined in terms of operative reaction. I think this is the most important aspect in terms of organization. We set up a crisis unit in which a multidisciplinary dedicated team every day meet each other. We implemented the available personnel closing the elective surgical procedure and the patient activity. And for all the healthcare personnel, we set up a specific training program. This is another important issue regarding how to treat, how to dress, how to organize the work, everyday work. Finally, and then we will come back on this issue, I think to protect the healthcare professionals is the first must. Probably at the beginning we didn't figure out clearly this aspect, but it's truly important. It's like to defend a castle. Otherwise, if it's a castle, there are too many infections. We have, for instance, in my division, we had 12 cardiologists out of 36 that have been infected. And then we can have other suggestions later.
Yeah, thank you for those messages. Simon, do you want to jump in?
Yeah, thank you. So I think we in the UK, we had some advantage in that we could see the experience from our colleagues in China and particularly in Italy, in northern Italy, and so had, I suppose, a little bit more anticipation of what might be coming our way. And I think the thing that I've learned more than anything else is that the extent of change that is achievable over a very short period of time where everybody is focused on the same goal. And it has really been quite an extraordinary process, I think, particularly in London, where until recently the majority of the infected patients were in the UK, but the coordinated planning has really been achieved on an unprecedented scale. And similar to the experience in China, we've been able to open large hospitals in very short space of time in unconventional locations, and that is now being replicated around the country. And I think there are, at all levels, there have been extraordinary examples of team working. And if I take some examples from my own institution, a lot of the leadership in doing this has come from the staff themselves, from our specialist nursing staff, from our cardiac physiologists, who have worked out the practical details of how they deal with the COVID patients within this new structure. And I suppose in terms of your question about what has surprised me most, and I think that is the abrupt fall off that we've seen in cardiology presentations. And I know that's been replicated both in Italy and Spain, and I believe in the United States as well. And that we really did not anticipate the scale of that reduction. And I have to say, I think it's probably caught us a little bit off guard. And we're looking to try and understand now on a national basis of why there is such an abrupt reduction in presentations, particularly for STEMI and NSTEMI. And of course, this brings up major concerns about standing up problems down the line. And the final thing I want to say is really just to echo what has already been said by my colleagues from China and Italy, and that is around the protection of our workforce. And we in the UK have had some problems with the distribution of personal protective equipment. I think that's now being resolved, but it is certainly, or some way to being resolved, but it certainly has not been perfect. And one of the issues that we've had is that whilst supplies coming through to secondary and tertiary care centres have probably been adequate, that certainly has not been the case for community care settings where we've had real problems, I think.
Thank you. Akriti?
So I think from the patient disease perspective, I was most surprised by the unpredictability, because we also see people getting readmitted after they were discharged and were stable. And so it seems like it takes maybe 10 to 14 days after symptom onset when they suddenly, very rapidly, within a matter of hours, can go from nasal cannula to being intubated. So that really surprised me. And the other thing was also when we're admitting these patients from the floor to the ICU, within 2 to 3 days, they go from relatively normal creatinine to non-oliguric renal failure to anuric renal failure. And the renal failure is so rapid that I don't think I personally have seen it to be in that frequency in my short career so far. From the perspective of the personnel, I would say I was very surprised by how flexible we are as healthcare providers, including from top-down administrators to the respiratory therapists and echo technicians. We all were able to come together in a very resilient fashion to treat the same disease. I was very surprised by how, whether you're a urologist, you're treating the same disease as an anesthesiologist, as a cardiologist, even the ENT people, even the peds pulmonary people are manning some of the ICUs. So yeah, and the last thing that I was very surprised by was the rapidity with which both patients and doctors embraced telemedicine. I think predominantly we're administering rest of the care by telemedicine, which is non-COVID, and that I think would probably stay with us even after COVID is behind us.
Thank you. You guys have all made some amazing points, and we get a worldwide perspective. I think just to emphasize that too, that there's the direct effects of the virus in those who are infected, and in the effects on all the other patients that we're caring for, and the health workers. Let me hand it over to Dipti to kick off the questions that we received.
Yeah, so Harlan, thank you so much. Those were really interesting perspectives, and we feel very lucky that you're all here today to talk about this. I mean, we think of COVID-19 as a respiratory syndrome, right? Severe acute respiratory syndrome. But we also know that there are significant implications for the cardiovascular care of patients. We know that patients that are elderly, patients with pre-existing cardiovascular disease, have an increased risk of severe disease and death. You've all alluded to that. We know that the infection, we've seen so far studies about infection having multiple direct and indirect cardiovascular complications, including myocardial injury, myocarditis, arrhythmias, and venous effects. And there have been reports recently that were published that said that anywhere from 7 to 20% of these patients suffer myocardial injury. A lot of the questions that we got from the people wanting to hear is they want to know about how to treat STEMI. They want to know about what has been the rate of myocarditis, pericarditis, what about cardiomyopathy. But I thought we'd start off with, we know that these patients have we're seeing this myocardial injury, we're seeing cardiovascular complications. So who should we then, when these patients get admitted, who are the patients that we should be doing biomarkers, regular echoes? Who should we be looking for that cardiovascular effects? Because obviously it's 7 to maybe 25%. So should we be doing it on everybody, or who are the right patients that we sort of say from the beginning when they come in, hey, this is somebody I'm worried about from a cardiovascular standpoint?
Harlan, should I?
Yeah, please.
Yeah, go ahead.
Okay. Yeah, continue to my previous information. I think at the beginning, in the early phase, we did think this syndrome is a respiratory disease, and we call pneumonia. But afterwards, I think it's really not so simple. Especially we see some of the younger patients in their 20s to 30 years old, that suddenly the patient develop this multi-organ damage. And therefore, I think, according to your question, I think for the first, I think for all the cases, if possible, we do recommend the CT for both lungs. But the CT is very specific. You will see the ground glass phenomena, and it's the change very fast. In the morning and in the afternoon, the second day, you will find the infiltration of this both lungs. CT is a very typical manifestation of this COVID-19. Actually, for the patient with some secretions, with a cough, so not so very frequently, but frequently is the patient develop the respiratory failure. Secondly, we analyzed our patient, and for the severely ill and the critically ill patient, nearly half for all patients with a mild or moderate elevation of troponin and the CRP and the D-dimer. Nearly all patients had elevation of D-dimer and interleukin-6 and so on. But the key issue is the hypoxemia. Therefore, if you ask what kind of patient should we do the troponin, if possible, I think for the severely ill and critically ill patient, I think we do all patients when possible. For the mildly, without, you do not need that mechanical ventilation. Maybe it's not necessarily or not so urgent. I think for severely, we see nearly half of them. It's not very severe elevated troponin, but moderate to mild. That means the damage of the myocardium. We do not have, for example, in this group patient, we have so many doctors from colleagues from all over China to Wuhan. We have from different hospitals. We have different regimens at the beginning, and it's not possible to do the biopsy. But in the early phase, we see the limited number of autopsy. We see infiltration of lymphocyte in the myocardium, but we do not have evidence of the virus in the myocardium. I do not think this is the main issue of the virus attack the myocardium itself. Maybe I think many caused by the inflammatory factors. We call maybe inflammatory storm or something like that. So we do see patients with a huge elevation of interleukin-6 and the CD4 so on. And we treated in our center 11 patients with elevated interleukin-6 with this antibody. Of 10 patients, we get a very nice result. The patient recovered soon and so on. I think anti-inflammation is also important. But I do not think that for all patients you test the troponin, but for the severely, as I mentioned, as critically ill, I think important. We can protect the patient. I had two cases, one patient with inferior myocardial infarction, another case with huge elevated CRP and troponin, and with injured myocardial function, with injured ejection fraction. But after treatment of myocardial protection, and also ECMO, the patient recovered. And the other, the first case with inferior myocardial infarction, because we do not have at the early phase in the mobile cabin hospital ECG recorded. We have all colleagues from either ICU or respiratory disease department. Therefore, they do not, just like Mark Twain said, if you have a hammer in your hand, it looks everything like a nail. And therefore, they think also in their direction. Afterwards, a week after, we recorded, because the patient gets hypotension, we recorded ECG, we found that the patient developed inferior myocardial infarction, and we give the transfusion, and so the patient recovers. I think importantly, so you have to identify severely and critically ill patients. For the mild, maybe not necessarily.
Anybody else want to add anything on that? Sahil or Michelle?
Yeah, in my experience, honestly, I think if the question is in which patient to perform troponin I or BNP, honestly, no one in the world can tell you exactly what are the patients. I think now is the time to study this patient. But if I have to select, first of all, I would start in patient with cardiovascular comorbidity in the history. This is for sure that they are the patients that are doing worse. Therefore, probably, if I have to select the number of biomarkers, the number of biomarker blood sample, I would say cardiovascular patient, because we know hypertensive probably heart failure patient with some cardiovascular arteriopathy and so on are the most affected in terms of outcome. of this patient.
So I'm going to push you. You're not suggesting that routinely you're going to do this. You're going to do this if they decompensate, like Dr. Geek said, right?
Right. And I think it's better to anticipate. I would not expect too much. I wouldn't say in the intensive care unit, because at that time, probably it's too late. And if we think of how is the natural history, if we can say, of this patient, to start with the viremia, so virus infection, and then move to the inflammation. Inflammation involves the heart and the other, but not only the lungs. If I can say, in our experience at the beginning, we thought that the problem was only the lungs, and therefore the pneumologists were truly involved. And then we figured out that something else happened, and that is the inflammation. And now we are trying to take care about this point, because the pulmonary lungs is one of the epiphenomenon of the problem, but the problem is still the inflammation, the truly high inflammation. And therefore we are trying to treat in other different ways. And regarding the myocarditis, I do agree. We didn't find myocarditis. We performed some autopsy as well, but we don't have the precise data right now.
Maybe some of the others like Colombia, and if there's this thing about the protocol that you're asking about, I think is lots of people wondering about screening everyone versus some people, and also what we do differently. Once you know the information that there's troponins, what does it change in terms of our approach? So maybe we just continue just a little more to hear what others are doing too.
I would just add that we've been trying to do handheld echo. It's not easy when the patient's prone or anything like that, but but before they get to that point, if you see the troponin going up, I think it's really important to try to establish whether this is LV or RV, because one of the things that I think has been noticed, not just at Rush, but around listening to my friends in the city, is the high degree of thrombogenicity that is developed. And so we're worried about in situ thrombosis, DVT, pulmonary emboli. And so if the troponin is going up and you see some evidence of right heart strain, that's probably someone where we should pull a trigger on anticoagulation or further diagnostics to try to establish whether or not this is critical pulmonary emboli. And if it's LV, then you know that this is a person who's got myocarditis. Now, what do you do at that point? One of the issues that we're seeing is sort of this bradycardia. And so if you have that combination of bradycardia and LV dysfunction, it's probably an easy choice to get them on a low-dose inotrope and try to get inotropy and chronotropy together.
So, but Kim, are you doing the troponins on everybody from the beginning?
Right, and the question is, where do you draw the line? Do you keep tracking them? The PEs tend to be flat. The myocarditis tends to go up if it's an acute coronary syndrome, which, by the way, we're not seeing. I would love to hear what everybody else is seeing. What I'm seeing around in the literature is a 20 to 40% reduction in STEMIs. We've had 100% reduction in STEMIs. It's just kind of shocking. And so everyone is using their own judgment about, the trend. Personally, if they're going up, I'm going to keep following them until they peak. And if and you have the tiny troponinomas that you get with a UTI in a 93-year-old when they're getting a bit septic. But when you get real numbers, that's when we're very concerned that this is an acute coronary syndrome.
I would just add that in New York, Akriti as a fellow gets called about every troponin elevation, as in many hospitals. So I think she could tell you the real story. But I think that our approach is very similar to what Dr. Williams mentioned. Certainly electrocardiography is definitely important. Everybody gets an ECG. To get into our hospital now, you have to go through the emergency department. Direct admissions and all those other portals of entry have been essentially shut down. So everybody through the emergency department usually gets a shotgun of laboratory tests, often including troponin and other biomarkers. And they also get an EKG, and the EKG can be helpful in identifying these patients. We likewise have seen the reduction of garden variety ACS, although I have to tell you, I'm on a WhatsApp group with interventionalists all over the New York tri-state area. And there's a lot of patients now presenting late in their course of myocardial infarction. and people are terrified to come to the hospital. And I was on the phone with a patient this morning just before coming on, who's having symptoms and is very reluctant to come in and seek care. And so I think there is some component of that that we're dealing with here. Akriti, how many times a day do you get called about an elevated troponin, I wonder?
So the interesting part is that people have stopped calling cardiology consults now because it is just such a universal phenomenon for troponin elevation. The thing that we are doing at Columbia is that everybody gets the whole panel of something that we call COVID labs, and they get ordered right up front on everybody, and they get trended every day. And that includes not only troponins, but all of the other inflammatory biomarkers as well. There's a low-level troponin elevation. We're doing high-sensitivity troponins at Columbia. The low-level elevation, I think, is very universal. I don't have the numbers, but I would, if I had to guesstimate, I would say at least in 60 to 70%, the majority of the people have low levels. But in people who have high-sensory troponins in the thousands, those are the people where we are prompted to do a handheld portable quick echo to see what's going on. And there are two distinct patterns of echo findings that we have found. And again, this is my anecdotal experience in 3 weeks of being in the unit, so I'm not generalizing anything. But one pattern is global biventricular dysfunction. This, for example, I can quote a case of a 45-year-old lady who basically no past medical history and presented with hypoxemia, looked actually really good, was talking without having to take a deep breath in between, but desatting a lot, and her troponin was in the 3000s, and her echo showed global dysfunction. She has had a very long course. She's still intubated. It's been, I think, 2.5 weeks. And the most recent echo did not show recovery of the myocardium. So that's one pattern. And the other is RV dysfunction and isolation. And I think RV strain, RV dysfunction would speak to what others have already said about the hypercoagulability and potentially PE causing RV strain.
So are you anticoagulating all those people with the RV strain pattern?
We have a very low threshold to anticoagulate right now. I think as opposed to China, I'm not sure, based on reading literature, not everybody gets prophylactic anticoagulation. In the US, everybody gets prophylactic anticoagulation, so that's a baseline. But on top of that, we have a very low threshold of doing therapeutic because we're seeing, firstly, a lot of line clotting. Like I've had to place A lines on people every day, like keep changing the A lines, keep changing the VASCATs. And then there are patients in whom the ECG would show a new S1Q3T3 pattern in the setting of increasing oxygen requirements. And we have been very judicious with CT scans. Like, honestly, in 3 weeks, I do not remember sending any patient for a CTA. So we are diagnosing PE clinically with echo and troponins and ECG markers. And that's how we are deciding about anticoagulation.
In your use, I want to just linger on that 1 second because it obviously very different from China. China's used to CT scans. China CT scans are very commonly used in a wide variety of areas, and people are used to thinking about them. You're not using CT scans because you don't want to transport them downstairs and put them into the scanner. Is that it?
Correct. Because
Harlan, the other point too is the dye load for a CT angiogram for PE. You're going to be giving 100 cc's or more of contrast. Yeah. And as Akriti mentioned, there's a lot of patients that are developing acute kidney injury. And so we're still sort of sorting that out. I think that a non-con CT, a high-res CT to look at the parenchyma is different than a CT angio.
Absolutely.
That's a really good point. Jumbo, were you seeing as much AKI, the acute kidney injury in China, and how did you manage that with regard to the CTs?
No, actually, we actually not for every patient. We recommend nearly all patients with fever suspected, especially admitted to the hospital, recommended to a CT scan of both lungs. Because to rule out if this patient, because the CT image is very typical, this ground glass phenomenon. If you see, you can, with fever, you can certainly sure to build a diagnosis. And we do not do the CT angio. And we also do not see a lot of patients with renal failure. But we do some CRRT in patients with severely multi-organ damage. And we do and also I want to point it out, I don't know the situation, Sahil, in your hospital, you do echo, you do something, because in the patient with admitted in CCU, in ICU, normally we have this level 1 protection. We using the PPE, personal protection equipment, and we not only with the face mask, we have this the glass mask, and with the whole dressing gown. And normally we recommend for at least 3 gloves. Therefore, for manipulation of any invasive diagnostic examinations is extremely difficult, especially for example, you deliver this patient to the cath lab or so on. Therefore, we do not recommend to patient to deliver here and there, but if CT is easier because we install the CT by this fever clinic, and the patient get easily CT scanned. It's much easier than also objective than the other method to rule out or to confirm the diagnosis of this infection of pneumonia.
Akriti, can you just tell us about what that COVID panel was? You mentioned the troponin. What other labs are part of that COVID panel that you guys do?
Sure. Interleukin 6, LDH, D-dimer, troponin, ferritin. What am I missing? That should be about it, I think. CRP, ESR, so the typical inflammatory markers.
And how does that change your approach based on those results?
Yeah, so I'm not sure if it's changing. Well, interleukin 6 changes the therapeutic approach, because if it's super elevated, then we will enroll them in the tocilizumab trial. But I can give you an example of a patient who had very classic catastrophic cytokine storm, where this patient is very young, 39 years old, and has cardiac history in the sense of having had congenital disease for which he had tissue, AVR, MVR, first mechanical, then tissue, AVR, MVR, redo surgery. But his myocardium is actually, myocardial function is preserved, and no other medical issue, who presented with classic hypoxemic respiratory failure from COVID, intubated, and has very high inflammatory markers through the roof for all of these numbers, and was spiking fevers up to 110 Fahrenheit that I have not seen outside of taking care of malaria or dengue in India. So that was to the extent that we had to use the Arctic Sun protocol to bring his temperature down. And so I think in addition to making decisions about utilizing anti-inflammatory drugs that we're testing in the trial setting, it's also an observation that we're making that I think we will go back and retrospectively utilize for research purposes and figuring out what are the markers of adverse outcomes.
I might possibly make a comment from a UK perspective. So we don't have a national protocol for tackling biomarkers. I mean, in many ways, I wish that we did, because I think the research strength of that would be enormous, and there are moves to do that, at least within selected units. But I think our approach is probably fairly similar to the one that's been described from Columbia, in the sense that we are pretty cautious, and certainly our recommendations are very cautious in the use of echocardiography, and that we will reserve that specifically for those instances where we think that that is going to make a difference, pulmonary embolism being one. And the anecdotal experience from units that have been doing more echocardiography in patients with relatively limited troponin rises is that the echo is often normal. And we're very concerned about the exposure of our echo-physiologists unnecessarily in high-risk patients. And so we're really being, as focused as we can in terms of delivering echocardiography in patients, and restricting it to those very specific instances where we think it's going to make a difference, and in particular where there may be issues around going on to mechanical support.
I don't know, Sean.
Yeah, I'll just share a bit about our Singapore experience. So I'm speaking more from an ID perspective. We have noticed with quite a bit of regularity that looking at our cohort data, that the people who tend to turn ill typically are those who might be 50 years and above in our Singaporean cohort. Clinically, they might have comorbids like chronic cardiovascular disease, diabetes, or morbid obesity. We also noticed that besides the clinical features of that you find, like the PF ratios or increased respiratory rate or dropping O2 sats, this tends to occur quite frequently at the end of the first week of illness. So if you're looking for a deterioration, for those who might deteriorate, we believe a nice paper was published from the guys at Harvard, I think Siddiqui et al. He had a nice model of the stages of the disease. I think it would vary somewhat from patient to patient, but there is a viral proliferation phase and then a cytokine phase, in between phase, and then a cytokine storm-like phase in some patients towards after the 7 to 8 to 9 day mark, and we need to watch out for it. I think the markers that we use routinely, the COVID labs we use in Singapore, we don't start off with troponins routinely for everyone, but we do get a CRP and an LDH. In our population, and I suspect it might vary from lab to lab, a CRP in our population of more than 60 or LDH of greater than 550, and I think the normal values might vary from lab to lab, have been fairly predictive of a worse outcome or deterioration, first in the pulmonic sense, and then after that, in some patients, multi-organ failure. The people that we see going into renal failure and cardiovascular issues have been those who first develop quite in a pattern. First, it will be a mono-organ involvement with pulmonary disease, and then after that, other organs get involved, and they have a septic, some of them have a septic shock-like picture needing vasopressors. Some of this data that I'm saying now comes from one of my colleagues, Dr. Chia Yu-Woon, who's a cardiologist. He tells me that 50% of the patients that have gone to ICU and we have done a troponin in Singapore have had raised cardiac troponins. Most of this were type 2 mechanism. And he thinks that a focused echocardiogram may help differentiate between type 2 MI as opposed to a type 1 MI where they might have regional wall motion abnormalities or global hypokinesia. The other thing is that a lot of our patients need increasing PEEP in that pulmonic phase, and that might also increase right ventricular afterload and also acute right heart failure. And sometimes if they have underlying poor cardiovascular disease with heart failure, even diuresis might cause patients to be hypovolemic in addition to the increasing PEEP. And that's where echocardiogram might be useful to guide bedside echocardiography to guide hemodynamic management. And lastly, I would just say that we are also looking at tocilizumab in some of our patients. And it is one thing that we find challenging and be interesting to hear from the rest of the panelists. Of course, IL-6 might be raised in these patients, and I think infections are indeed, these viral infections are a pro-inflammatory state, and we should not be that surprised that thrombotic events are more likely. And one thing we are trying to do is to try to establish between COVID patients who are in the general floor, the general ward, versus COVID patients who are sick in the ICU, do they have a different cytokine profile? And I think it's not just the absolute values, but the trajectory and the pattern. Some preliminary data when we have measured IL-6 in a cohort of patients, just in the general floor, we're looking at values, mean values about 18 picograms per mil, and then it goes up about 8 days later to 30 something. But I think we don't really know how to interpret these values, and I think we need more values from various parts of the world and various ethnicities and countries to try to establish what a patient who's turning ill looks like in terms of these cytokine profiles.
I had a question for you all. I think this is right in, by the way, that just to emphasize the importance of international research collaborations. I think it's going to be important for us to work together. And I'm already hearing different patterns in different countries of the manifestations and trying to understand that. Recently in the US, there's been some discussion about whether mechanical ventilation has been overused and whether there may be some premature use of it, and also concerns about management and prognosis associated with it. I just wonder if people could reflect on their criteria for mechanical ventilation and decisions about early versus late, and also the use of proning, which has now become quite common in the management of these patients. So I just wonder if people would share. This is just a very concrete question, but I think it comes up a lot as people are thinking, when are we using proning? When are we intubating? And, should we be trying to do it earlier, or should we be really trying to defer it much later? So I don't know if anyone wants to comment on this. Not exactly a cardiology question necessarily, but it's one cardiologist facing as we go to the ICUs and are being put in positions where of managing these issues.
I can speak about our ICU protocols that we're using. I think we're erring on the side of early intubation, and the way we're making decisions are, so we're totally trying to avoid non-invasive positive pressure ventilation as much as we can because of the aerosolization from that. And so even though in the ED, they do sometimes do the BiPAP thing, but predominantly on the floors, what is happening is that people will be on nasal cannula. If they're desaturating, they will go up to non-rebreather. And if on a non-rebreather mask, they're still continuing to desaturate, and the blood gas shows a PF ratio of, let's say, less than 200 or less than 150, and they're struggling to breathe, then we directly will go to invasive mechanical ventilation. And then once intubated and fully sedated, if then the PF ratio continues to be low, less than 150, then we would think about paralysis. And then if after paralysis, we're still continuing to see low PF ratios and difficulty to ventilate despite very high PEEP, very high FiO2, then we are going to proning. So that's how we have been doing it at Columbia.
In Singapore, in one of our early protocols on when to intubate, this was what was written. Respiratory rate more than 30 if they have a FiO2 of more than 50% by face mask, or if they are hypotensive, needing vasopressors. This was earlier in the outbreak. Since then, we have, interestingly, some of our pulmonologists have adopted awake and non-intubated self-proning even before they get to the ICU. So they start with intranasal oxygen and they do regular awake proning. They suggest, at least at our institution, proning for 1 hour, 5 times a day. And they even have a YouTube video, which I might just type out the link. And I think several places are doing it. And then if they are uncomfortable proning in a proning position, they could do left and right lateral decupitous proning. Then after that, if they are still hypoxic, we might move to a venturi mask. Like RKT, we try not to do non-invasive ventilation like with BiPAP, because we feel that if they need to be intubated when these measures fail, then early intubation is important. But before we get to intubation, we try high flow nasal cannula or oxygen rather than intubation. And we have been able to avoid intubation for some patients who can do HFNC and proning. And once they get intubated when they are getting more severe ARDS, we have found that proning does really help before we have to get to other interventions like ECMO and all that. In the country, so far, out of about 1,600 patients, about only 3 patients have been started on ECMO.
Sorry, I wanted to also add, just based on what you said, because I was giving you the ICU perspective, but on the floors, we are also proning in non-intubated patients. And I think they are anecdotally observing benefit from that and potentially less need for intubation.
So you actually, Sean brought in a good point about ECMO, because there were a lot of questions about ECMO. Are people using ECMO in this population, and what has the success rate been? And also about what are the clinical indications and timing for mechanical circulatory support in these patients?
I can again give a bit of a UK perspective on that. So ECMO provision in Britain is relatively limited. It's organised on a structured regional basis, and there are specific protocols for patients who are heading in the direction of mechanical support. And our institution is we provide the ECMO service for the northwest of England. And I think talking to our intensivists, what we're seeing is a patient journey, which would be somebody comes into hospital, they're requiring oxygen support. They may require that for a few days. They go on to mechanical ventilation, which is at the moment our standard, although we are thinking about the use of non-invasive ventilation more. That we have a pretty aggressive protocol for proning 16 hours a day, and that if at that stage there is continued failure of oxygenation, particularly coupled with hemodynamic instability without specific underlying cardiac cause, then we are we're putting people onto ECMO. The numbers at the moment are relatively small. As a matter of routine, we would have the availability for 5 or 6 ECMO patients in our centre, and we're I think yesterday we were up to capacity on that. We now have the capacity to expand that quite a bit more, but we are very rigorous in terms of who would be eligible for ECMO. I mean, very clearly these are people who have no other major comorbidities, who there's a reasonable expectation of them coming off. So far as I'm aware, in our own institution, we have, although we're at a relatively earlier stage in the course of the pandemic than it would be in Northern Italy or New York, certainly China, we haven't had anybody yet who has been successfully weaned off ECMO. And so I think there is, the concern we have, as has already been alluded to, is that once these people are ventilated, they tend to stay ventilated for a long period of time. And I rather suspect that that would be the case with the ECMO, but it's going to be very interesting to hear what other people's experience who've had, say, larger or longer experience of patients on ECMO, whether their experience is different from that.
I'll just say what we have done. We have had only 3 patients on ECMO so far, and not all centers in Singapore are ECMO capable. So it's important to define criteria to transfer to an ECMO center prior to the patient becoming too ill to get on a transport ventilator, for example. So in non-ECMO capable centers, once they are thinking of proning the patient, we encourage them to think ahead whether they might need to transfer to an ECMO capable center. And the general criterion we use for that pre-consideration is despite ventilatory support, a PaO2 of less than 70 mmHg or less, or FiO2, while on a FiO2 of 50% or more. And the country has some ECMO criteria which are quite stringent, including age-based criteria and also looking at their comorbidities. But to get onto ECMO, of course, then they would, the general criterion is that they have a PF ratio of less than 80% with a FiO2 of more than 90%, despite optimizing the PEEP and other adjunctive therapies like paralysis and proning. The limited experience we've had in Singapore, and I think our other colleagues all over the world might have had more experience, but of the 3 patients in Singapore which have gone on ECMO, actually one went into PEA arrest prior to starting VV ECMO, but thankfully he was successfully resuscitated and he had to be converted to VA ECMO. Later on, he had a tension pneumothorax and had a chest tube inserted, but actually he did well eventually, and he survived the PAA, and he was decannulated. I don't remember his age offhand, but I think he was relatively young, in his 30s. One of the patients in our unit was started with ARDS on VV ECMO, and unfortunately, despite therapeutic coagulation profile in terms of his PTT, he developed intracerebral hemorrhage, and he expired from that event, and that was very sad for us. And he had been on Plavix prior to, and we've had underlying ischemic heart disease. We're not sure, and we don't think that the Plavix ultimately increase the risk of hemorrhage. We're not sure. I think the literature, some literature indicates that being on Plavix beforehand does not overall, in at least some studies that I've seen, and I'm not a cardiologist, that it has not increased the rates of intracerebral hemorrhage, but I'll be interested to hear the opinion from this group. And we are wondering whether, despite the prothrombotic state described in COVID, whether there is also a concurrent coagulopathy. And that's something which I'd be interested to hear from your experiences. The third patient who was on ECMO did well. And so far, I think he's still cannulated, but he also had melena, and we're not sure where that's coming from, whether there's some underlying coagulopathy. And we have seen GI bleeds, even in those who are not anticoagulated in our population. So be interesting to hear the group's wisdom.
Yeah.
Actually, I think a week ago we discussed with Harlan regarding Dr. Juning, my fellow, because he working in this ICU for 2 months. He introduced the 5 cases with ECMO, but all patients recover well. What his advice, because in the 7th edition of this Chinese Health Commission, we have recommended specifically the indication for ECMO is just like Siobhan mentioned by this FiO2 more than 90% with the oxygen saturation index of less than 80 millimeters mercury, last for 3 to 4 hours. And the average pressure from the respiratory tract was more than 35 centimeters. I think it is indication for ECMO. But according to Dr. Juning, he said, if you plan to do ECMO, do it earlier, not till that the patient is exhausted or till the multi-organ damage. And this will no use. And therefore, he will advise that if you want to plan to do ECMO, do it earlier, and this will really save the patient. He introduced, I think, all the 5 cases, 4 cases with VV ECMO, and 1 with VA and VV ECMO mode. What we believe the VV ECMO is very effective because it will help the patient to recover, to help for the oxygen saturation. And by the VE mode, the concern is maybe it will increase the afterload of the patient. If the patient with elderly patient with, for example, injured left ventricular function, it might probably not helpful. But he introduced all these 5 cases all went well. And I think if we want to do it earlier. And another thing important is we also, before to implant the ECMO, we will put the patient to a prone position. This will help patient to really to the air exchange.
If I may say just a few comments, a short comment regarding first of all, the overuse of mechanical ventilation. Honestly, I do think that the risk of staying in non-invasive ventilation is to have too many emphysema due to the fact that you are forcing the PEEP in the CPAP. And this is a problem. And the same thing, I do agree with the Chinese experience that we have to anticipate the use of ECMO. Right now, we have 8 out of 8 ECMO out of 88 intubated patients. And VV, most of them are VV ECMO. So I think that this is important, don't to wait too much, because otherwise, if we saw some autopsies of the lungs, for instance, and most of the time the lungs are truly destroyed. If you wait too much, it's too late to have a winner in terms of weaning from the ECMO or from the mechanical intubation.
Dr. Krumholz, I think you're muted. Can't hear you.
Thank you. I just have a quick question, and Dipti, I was thinking maybe we could just jump to a couple quick ones, but we brought up this issue of the protection of the healthcare workers a lot. I just wonder if you could just reflect quickly on what you're doing. I mean, we've heard 3 gloves, we've heard in use of masks, but also who are you keeping off of the front lines? Have you said older doctors shouldn't be on the front lines, and what's your age cutoff? And what about doctors who have underlying conditions? How are you, and of course, everything I say about doctors also goes for nurses and all healthcare workers, so I don't mean to be just specific to doctors, but can you just quickly reflect on your policies about this?
Sure.
I should jump in.
We do not have age, not have age cutoff for any patient, I think. For in China, we have, for example, a person who's in charge of to check all our personnel who enter to the ICU. You can, for example, the inner part, you can wear by yourself, but afterwards we have someone to check. This, I think, give us the lesson we have learned that for the 42,000 people, no one got infected. And we tested also in the ICU, we put swabs 3 hours after we test, we find the virus. We also had the handle of the door, but in the handle of the door, we find the virus. I think it is extremely important. I see it again. I would really appeal to everybody who work in the ICU to get checked by a specific person, not by yourself. And if you get out, you also check by a specific person to take off all your protection equipment, not by yourself.
That's really good advice. And at Rush, just sort of, we do have sort of a bimodal faculty, younger people that I've recruited and the older people that I inherited, myself included. And there were a lot of concerns expressed, and the expresses was really on both sides. We had older people, particularly the males, looking at the Chinese experience and saying that they really didn't want to expose themselves and their families. And then the younger people saying, well, why should we bear the burden because we happen to have a fair amount of older faculty. So this was one where the Rush upper management really had to come out with a policy, which was very reasonable, saying that anyone with any risk factors, any person over 60, they should have the option to and feel free to inform leadership, and that would, in this case, it would be me, and that I should redeploy them. And so we have older faculty who are sitting at home and read all the echoes that are done in the institution, and another one is sitting at home and reading every EKG that's done in the institution. Others are actually upticking their video consult visits and seeing outpatients by telephone and video. And so once it was policy, then the younger people were not so concerned. The other side of it is that we had a fair number of people who normally, since I'm not just a nuclear cardiology guy, where we're used to in the nuclear lab, everyone declares their pregnancy right away. Outside of nuclear and CT and cath, people don't declare their pregnancies right away. And it turns out that there were a fair number of pregnancies that we didn't know about. And so those were also taken into consideration. So there's a large number of people that we're not deploying for those reasons. And I think the onus is on the institution and leadership to give people that option.
Sahil, do you want to just say Columbia's approach?
I think it's fairly similar in that, there is some self-segregation. Patients, or rather faculty and providers who are in one of those categories that Dr. Williams mentioned are able to tell us that that they are perhaps best redeployed in other venues. But by and large, we've actually had the opposite problem of everybody wanting to, in the all hands on deck analogy, participate in any way that they can. And so our leadership has been particularly fastidious about, vetting any potential high risk factors and deploying people appropriately.
And how about your use of PPE outside the ICU? How are you managing that?
So we're currently everybody has a face mask on all the time. And once you walk in the institution, that includes not just the providers and the healthcare workers, but also anybody that comes to the hospital and any guests, if any, that are allowed in the hospital. And that was an evolution. It started out with selective use, and now it's a uniform policy. And I think, like most United States centers, are using N95 masks in the intensive care unit with a face mask over it and sort of CDC guideline based PPE. At first, we thought we might be overdoing that, but certainly now we are using it quite uniformly. We do not have the sort of so-called hazmat suit type of gear that we see on television from outside the United States in certain places, and we've had our own internal conversations about that. But that isn't our standard in the ICUs. And Akriti could probably, since she's donning and doffing multiple times a day, can probably tell you exactly the current state, because it seems to change on a regular basis.
Yeah, I think in the last 2 to 3 weeks, I've seen the evolution. When I started rounding 3 weeks ago, even in the ICU, we were wearing only a surgical mask, but that has really evolved. And now you would see every healthcare provider wear first the N95 and then one surgical mask with a face shield over it, then a bouffant on the head. And people are also wearing, I think everybody has access to scrubs now. They're also wearing booties over their shoes. So effectively now in the ICU, everybody seems fully covered from top to bottom.
And in the floors?
I think floors, it's surgical mask.
No, in gowns in the rooms?
Well, if you go in a patient's room with COVID, then you would still obviously.
And how about non-COVID?
Non-COVID surgical mask.
Just surgical mask. Okay.
What about the clothing? What about when you go home too? There was a question about what do you do when you go home? Do you take your clothes off and wash them and not expose the other people that you're sharing your home with to that? Is there any recommendations with regards to that when you?
We have been lucky at Columbia that they have provided scrub access to everybody, every healthcare worker, no matter in what capacity. So at least personally, what I have been doing is that I change into new scrubs as soon as I enter the hospital, and I change back into new scrubs when I'm exiting the hospital. So when I'm leaving the hospital, I'm going back in new laundered scrubs. So that's not been a problem for me.
I think many of us have developed a decontamination station at home where, when we wear our clothes from home to the hospital, change immediately, use PPE all day, and then on the way home, change back. And then when we get home, before we get inside, at least in my case, it's in the garage, you change into something fresh and then run to the shower and then leave those clothes in the garage to sort of decontaminate and wash everything in as sterile a fashion as possible. But this has led to a lot of challenging conversations at home. Many people are choosing not to go home, particularly those in the front lines. In New York, there's been provisions made for hotels and other venues of care. I know in China, they've done a tremendous job of isolating healthcare workers from others to avoid community spread. And I think it's not uniform in policy. Everybody's coming up with their own sort of algorithm but we're trying to be fastidious about not exposing families and other people outside of the hospital.
This is where I'd love to hear Sean. Sean, from an infectious disease standpoint, what's the recommendation?
Yeah, so in our patients where we are caring who are COVID positive, we wear N95 masks and eye protection, and we would use either a visor shield or a visor mask, visor shield or goggles. The advantage of goggles is that we can wipe down and reuse them, especially when at one point our visor eye protection, our visor shields were in short supply. But since then, we have made our own. So we use 3D printing, and the hospital actually literally has an engineering lab, and we have made our own supplies of visor masks. We're still fine-tuning the plastic because some people have complained of being dizzy because of the light reflection. So we are still troubleshooting that piece, but it has ensured that we have a steady supply of visor masks. For people who have longer hair, then we have a hair net, and we use a gown and gloves. We don't use boot covers in our room. One of our colleagues did an environmental sampling survey using air samplers and sampled multiple surfaces across the room. Like some of you have said, there is widespread environmental contamination on the floor and some of the air vents that he found, especially around the patient's area in the immediate vicinity. Interestingly, in the first study, we did not pick up a lot of PCR positive samples in the air sampler, but when a different air sampler was used in 2 of the 3 rooms, it was a small study, and we are hoping to look at this a bit further. Concerningly, what is considered airborne is less than 5 microns. In some of the air samples in 2 rooms, he found PCR positive viral RNA, and this were from patients who were early in the illness. And we know from our studies in Singapore that viral shedding and the highest diagnostic yield of a PCR test is highest from the upper respiratory tract, either the throat or the nasopharynx, in the first week of illness. That's when people are most infectious and you're most likely to get a positive PCR test. When you go into the second week of illness, when there is pneumonia, your chance of getting a positive PCR from the upper respiratory tract in one study that we did and we have not published yet drops to about 60 to 70%. So the yield is lower, and lower samples like ETT, aspirate, or sputum would be much better. In some patients, we even had to diagnose it. The only positive sample was stool. So we are using such PPE, and then for people who are working in our outbreak wards, we provide them with scrubs. They come in their street clothes. Before they get to the wards, they change into the scrubs, and then they change out when they get out. The folks who are not in outbreak wards wear their street clothes, but everyone in the hospital has a surgical mask up policy. We adopted it very early in the outbreak, and I would say please watch out. People in healthcare are more likely to get COVID in the community, in the pantry, in the office area, rather than when taking care of patients. And that's what we have seen with our healthcare workers. We have had a handful of healthcare workers, but when we contact trace, I think it's the social gatherings. I mean, I really like to sit and eat and have lunch with my colleagues, but maybe now is not the time, and you really have to encourage, and it is not natural, but to have this surgical mask up policy in the hospital. Just last week, we adopted it for all our office meetings. We used to say 10 or more people mask up. Now it doesn't matter in the office. If you're someone else, wear your mask, because when someone comes down with COVID, there will be many people around that person who might have to go into self-isolation or quarantine, and you don't want to down your workforce. Just one person getting COVID might down your whole cardiology or ICU or ID team. So be very careful about that.
So Harlan, we're coming towards the end of our time. Do you think we have maybe one more question?
Well, I think what would be great is if we just give everyone a chance to just say, what's your message to everyone out there based on what you've known? Because I know we've only got a few minutes left. Would that be okay, Dipti, if we do that?
Yeah.
And so let's just go in the same way we did before, and just, you get a chance now to talk to all these people. This is also recorded. Many more people will be listening to this. If you had a message for them to think about, of all the things we've talked about that you want them to keep in their mind, and we don't want them to go through the same evolution. We want them to start on top of what you've learned rather than have to go through again. So Sahil, do you want to start?
Yeah, very simply, I would say prepare as much as you can, and protect yourself as well as you can. Those are the two most important things, I think.
Kim?
So my message would actually be a little different. We've actually had in the last couple of days the recognition that there are folks who in Chicago who have less access to care, poorer health profiles, are really having a higher mortality rate, and it's our African American community. We had multiple opportunities to get together, and we did it on occasion with other institutions, the practitioners in the African American community. We actually are embedded in one of the hospitals on the south side of Chicago that is Rush Cardiology, as the rest of Rush isn't right now. And that place is doing well. Our place is doing well, but particularly the south side is really suffering, and it has to do with protocols. It has to do with lack of intensivists, as well as late presentation of the people, and the high degree of risk factors, particularly hypertension and obesity. So if I had a message, it would be anyone who works in an area where there are vulnerable populations to try to reach out to them. So we're in the process of doing that now, and we're talking about transferring people, sharing expertise, e-consults, whatever we can do to try to help these folks, because we may have it together at our institution, but there are people outside of our institution who are dying.
Jimbal?
Yes, my information is I would really again to emphasize that no matter who you are, and especially you working in the room, in the ICU, I think I really appeal to everyone, especially to the health providers who are working with the COVID-19 patient, to protect yourself. Not only the surgical mask, not only the N95, it's not enough. You have to really working from top to the bottom, also including shoes. And you imagine it's 42,000 medical personnel not infected, is because we are isolate, we quarter all our medical personnel in the hotel. We do not let them to contact to anyone, to their family members. And after this, they finish this task, they have 2 weeks isolation in the hotel to see everything normal, and they can go home now. Otherwise, I think you cannot really block or cut off the transmission. I think this is extremely important, because if you see that in the early days, one sparkle, you will fire the whole world. I think it's very importantly to cut off the transmission.
Great. Sean?
I would say, besides what everyone has said, to prepare, to keep your spirits up. As a healthcare community, we will get through this. The tunnel seems long, but smile and encourage your colleagues. We all have stressful days, but as you keep, they can't see the smile in our hospital. We say that you cannot see the smile through the mask, but they can see it in your eyes. So keep your spirits up and keep encouraging one another.
That's great. Mikhail?
I think that, clinician and nurse are living a stressful condition caused by concern about their own health and safety, and also severity of this infection. But also, I think one of the most hard thing to say is seeing patient die alone. This is terrible. And therefore, I think a psychological support should be considered in specific case. So be aware about this. Sometimes you see colleague, nurse that are crying, and you are, as a chief, I can say I have to pay attention to this. It's truly important. It's a long, long war. So we need to take care of our clinicians, our colleagues.
So important. Simon?
Well, I would like to endorse everything that's been said, and I suppose the only thing I can add in addition to all of that is that whilst the focus for the moment has to be on COVID patients, we do need to keep one eye on the other cardiovascular patients that are out there to make sure that they are not seriously disadvantaged, because as we all know, there are patients with cardiovascular conditions whose mortality is going to equal or exceed that of COVID patients, and we will be doing them a disservice if the entire focus of attention moves solely onto those with COVID, as great as the need may be.
Akriti?
In addition to everything that others said, I would just like to remind people that these patients do not have their families at the bedside, who normally are strong advocates for patient care. And so not to forget that they are still part of the family, and especially for residents and fellows, to make sure that they call the families after daily rounds and update them about everything that's going on with the patient. And I think that's very crucial for the family.
I just want to express my deep gratitude to everyone. This really demonstrates how we are all one community, one world, one group that's in this together, working across, learning from each other. And I want to thank you. Hand it back to Dipti for final words. Thank you.
Yeah, I would say the same thing. First of all, I want to thank all of you for being on this. I mean, I think as a medical community, we really have come together with this public health crisis. I think we're all actively engaged in trying to have real-time data gathering, and we're helping to facilitate learning amongst ourselves as well as our larger community. So and sharing best practices. And I think this is what this is all about. And so we're very grateful. I think that this is a very large topic. We've had about an hour and a half, but there's clearly a lot more that we can all learn from each other. There's still a lot more questions that we've left unanswered. So I want to remind everybody that at the end of this webinar, first of all, this will be posted on acc.org and on the COVID hub so that others can access this information. Also, there were so many questions we did not have time to address, and those will be answered and posted on the hub so that we will get to a majority of the questions that everybody had. So I would say I agree with Sean, we need to keep our spirits up. We need to smile under our mask. I think, what you said about family members, to keep them in the loop is very important. I think this is a time to support ourselves, to support each other, and to support the families and our patients. So I want to thank everybody, and please tell your colleagues about this, those that are on the webinar right now, so that others can go on acc.org on the COVID hub. So thank you. And Harlan, as always, it's been wonderful moderating this with you.
Thank you. You too, Dipti. And to all of you, our deep gratitude and deep appreciation, and wish everyone strength, be safe. And let's continue to all work together, both everyone on this call and everyone listening. We all have to hold hands and be one community working together hard to make progress. Thank you.
Stay safe. Thank you.
Thanks so much for having us.
Thanks so much. Bye-bye.
Thank you. Bye-bye.
Bye.
Thank you.